Assalamu alaikum. Today we will talk about hospital-acquired pneumonia and ventilator-associated pneumonia. We will discuss the definition of HAB and VAB, and we'll identify the high-risk patients and how to select the antibacterial for those patients according to their risk. All will be discussed according to the American and European guidelines in 2016 and 2018. Case number one. A 50 years old patient, male patient, admitted to the ward after cholecystectomy. The patient has no previous history of hospital admission and did not receive any antibiotic in the last 3 months. 3 days later, the patient started to develop fever and productive cough. And there's the chest X-ray for this patient. It was not conclusive. The vital sign of the patient was stable, slightly tachypneic. PO2 is 80, and patient was slightly confused, and the TLC was 14,000. This case is diagnosed to have query HAB, and we'll discuss why it's query HAB. The case 2, 38 years old male patients admitted to the ICU after diagnosed to have COVID pneumonia. Patient upon admission was severely hypoxic. SpO2 in the room air was 70%. Non-invasive mechanical ventilation was started, and SpO2 improved to 96% on FiO2 0.5. After 5 days, the patient started to develop high-grade fever, productive cough, and SpO2 dropped to 80% on FiO2 90%, and patient intubated and mechanically ventilated. CT chest was done for this patient, and it revealed right middle looper consolidation. Vital sign was stable. PO2 was 60 millimeter mercury on FiO2 0.6. This patient is diagnosed to have a COVID pneumonia complicated with HAP. Case number 3, 35 years old male patient admitted to the ICU after road traffic accident, brain contusion, left femur fracture, large left hemothorax were diagnosed. Patient's glaucoma score was 5, endotracheal tube intubation was done, and 3 days later, patient started to develop productive cough and fever. Empirical antimicrobial was started with CVP monotherapy. 2 days later, the vital sign was 80, blood pressure was 80 over 30, patient was tachypneic, hypoxic, and chest X-ray revealed right middle looper consolidation. And this patient was diagnosed to have a VAB complicated with septic shock. So, what is the definition of HAB and VAB? The definition of HAB and VAB divided into according to the situation of the patient, is he is intubated or not, and according to the onset of the symptoms. The hospital admission, if the patient had diagnosed to be hospital-acquired pneumonia, the duration up to 72 hours after admission to the hospital or to the ICU or the emergency department. While the ventilator-associated pneumonia is extended up to 72 hours according to the CDC guidelines. It's not only 48 hours; it's extended to 72 hours in both HAB and VAB to diagnose or to suspect that the patient have the risk of or diagnosed to be to have hospital-acquired or ventilator-associated pneumonia. So diagnosis depends on the diagnostic criteria of HAB and VAB includes the first, the radiological sign, single X-ray in patient with free medical history. It's important. So the first patient who says that it might be hospital-acquired pneumonia or not, because chest X-ray was not conclusive. So we have to do CT chest if the chest X-ray is not conclusive, or if there is a new progressive lung infiltrate with 2 or more serial radiographs, either it is CT or chest X-ray, with at least one of the following or two of the following. One of the following, there is high fever without any other cause. There is leukocytosis or leukopenia, and at least two of the following: purulent sputum, cough or dyspnea, declining oxygenation or increasing the oxygen requirements or need for respiratory assistance. So case number one, as we said, as inconclusive. So it's clearly hospital-acquired pneumonia. So we have to do CT chest for this patient, but we have to start empirical antimicrobial. And but case two and three, both patients were diagnosed to have a hospital-acquired pneumonia or ventilator-associated pneumonia. The radiography for this patient is CT chest for first case is confirmatory, and we have to do it. We can use also lung ultrasound, which is the more sensitive, and the X-ray for more than sensitive than X-ray for diagnosis of pneumonia. And should we take qualitative or quantitative sputum culture? It's according to the different guidelines. The American guidelines, yes, we can go for semi-quantitative culture. Is it moderate or heavy, heavy bacterial growth, or and while the European guideline go for the quantitative form from the airway. If it's from the distal airway, up 10 to the power of 4, it's okay to confirm the diagnosis of the HAP or VAB or any respiratory tract infection. But if it's taken from the trachea, the proximal airway, 10 to the power of 5 is mandatory to confirm our diagnosis. So what about the patient risk? Patient risk, it differs according to both guidelines. The American guidelines 2016 stated that if the patient has risk factors depend on organ dysfunction and factors that increase the MDR, like the prior IV antibiotic use or more than 5-day hospital stay prior to that. Why the European guidelines stated that the risk factors depend on the mortality risk, like the American guidelines, they go for the duration of hospital stay, the previous colonizations, poor prior antibiotic use in the previous 90 days. Also, there's the local ecology for and risk factor to increase MDR. It's important. It's a very important risk. If the there is more than 25% of the sample of the pathogen was MDR, so there is high risk for MDR in the patient to catch from the either ICU or the hospital. Also, if there is more than 10 to 12% of the patient, 20% of the patient have the positive staph for MRSA, it's high risk to have positive MRSA during this hospital stay. So it's very important to know the local ecology for each hospital. To the patient risk of MDR, either is low MDR or high risk of MDR. The patient risk of MDR, is it risk of MRSA or it's risk of multi-drug resistant gram-negative bacteria? For both groups, to have the high risk if there is a previous use of intravenous antibiotic in the last 90 days. For risk of MRSA, if we have 10, as we said, 10 to 20% of the staph isolates are MRSA. Okay, or the patient have a previous colonization of MRSA within the last 1 year. At the risk of MDR or gram-negative bacteria, any of the following, as we said, 25% of gram-negative isolate in the hospital are MDR. Patient are in septic shock at the time of VAB, ARDS preceding VAB, renal replacement therapy preceding VAB, or more than or equal 5 days of hospitalization prior to VAB. How to choose the antibiotic for the patients? A very important point during management of those patients. The patient at risk of MDR, low risk of MDR, we can go for single antibiotic. plus or minus coverage of MRSA according to the risk factor or prevalence of MRSA is not known. It's very important. If we don't know we have no culture based or no antibiogram available, or stewardship is not available in the hospital. So we have to give or have to cover MRSA if there's the prevalence is not known. The high risk of gram-negative bacteria, we have to use MDR. MDR gram-negative bacteria, we have to start with two anti-pseudomonal from two separate classes. The lower guidelines stated that we can go for piperacillin 2022, the piperacillin tazobactam, or cefepime, levofloxacin, or meropenem, plus or minus MRSA, as we said. And the high-risk patient or MDR, we have to start with meropenem, never to use piperacillin, cefepime, levofloxacin, or other spectrum, combined with either aminoglycoside, levofloxacin, or colistin. So the first case had a low risk of a gram-negative MDR, so we can go with piperacillin, cefepime, levo, or meropenem, plus or minus MRSA according to the local ecology. The case number 2, this patients had a high risk of a gram-negative bacteria, COVID-19, the previous COVID-19, so we have to start with meropenem plus aminoglycosides and plus coverage of MRSA. Also, case 3 is the same as case 1. This patient has septic shock, the high risk of MDR, so we have to give meropenem combined with aminoglycosides or levo or colistin plus coverage of MRSA. So, how to adjust the antimicrobial according to culture? So in case number 1, the patient starts ciprofloxacin, patient is clinically improved, and the culture from the lab reported gross revealed Klebsiella pneumoniae. So should we continue the same antibiotic, switch to piperacillin, add piperacillin tazobactam, if the patient is improving and is continue on the same antibiotic, even if the culture giving the another antimicrobial sensitivity and your patient is improving, never to change the antimicrobial, but cover the duration of antimicrobial, as we will see. The case 2, a combination therapy of vancomycin, piperacillin, and tazobactam was initiated, but the lab reported growth of Acinetobacter in the sputum sensitive to colistin and Tigicil. So, and the patient was not improving. So we switch to carbapenem colistin, switch to colistin Tigicil, or switch to colistin Tigicil and inhaled Tigicil. We will switch to Tigicil, colistin, and inhaled Tigicil because it is severe form. There is a very big debate according to the when and how to give the inhaled colistin. We will discuss now. So the antibiotic adjustment, we should ask ourselves 3 important questions. When to add carbapenem to the combination therapy of pathogen resistance to carbapenem, when to use the inhalational antibiotics, and how to start inhalational antibiotics. So as we said before, for patients with carbapenem resistance infection with imipenem, MIC less than 8 milligram per liter, we consider carbapenem combination therapy using a high dose and extended infusion, 2 grams every 8 hours over 3 hours. Okay, so when to use inhalational antimicrobial, nebulized colistin or aminoglycoside, use in HAB due to MDR gram-negative bacteria susceptible to colistin and or aminoglycosides when there is no other antibiotic can be used, or other antibiotic should be combined with colistin as a Tigicil. So do not give inhalational antibiotic other than colistin or aminoglycoside. Do not give inhalational colistin or aminoglycoside if the pathogen resistant to this antibiotic. Never to use it empirical. Give inhalational colistin aminoglycoside without systemic administration. Do not combine inhalational colistin or aminoglycoside with systemic beta lactam. So once we should start colistin or aminoglycoside as a nebulizer, we should combine or add the colistin aminoglycoside IV form. So how to use inhalational antibiotic if the patient spontaneously, what a type of, as the first, what type of nebulizer? Never to use the jet nebulizer, ordinary jet nebulizer. Never we use the mesh nebulizer to allow these very minute particles to reach to the distal airway. It should be not more than 15 centimeter away from the Y piece of the attached to the patients. If the patient is mechanical ventilator, never to use spontaneous mode. You have to give tidal volume of 8 ml per kg, respiratory rate not less than 20 per minute. We have to use a pause to allow the uh, nebulizer to be stay for a long time in the respiratory tracts, 20% for 20% pause. The beep not less than 10 centimeter water. The antibiotic dose should be given the highest dose, 1.5 to 2 million and 6 ml 3 times a day for colistin, while for aminoglycosides use 40 milligram per kg per day in 6 ml in divided doses. So the case 3 sputum biofile was ordered and revealed the following results: pathogens with Klebsiella pneumoniae and the gene resistance with OXA48. So should we go for carbapenem and colistin, ceftazidime, avibactam, tigacercolistin? This is this culture. This the the biofile revealed OXA for 48, which is sensitive only to ceftazidime avibactam. So we have to give ceftazidime avibactam without combination. One of, as we said before, that OXA48 is one of the carbapenemase resistance gene, was only sensitive to the ceftazidime avibactam. And this diagram, as we said before, we see that the OXA48 is sensitive to ceftazidime avibactam, and the susceptibility of about 80% for ceftazidime avibactam. So what will be our recommendation for these patients? For patients with carbapenem resistance enterobacteriaceae infection susceptible to and treated with ceftazidime avibactam, we do not recommend combination therapy. For how long? It's very important issue. For how long we should give the patients the antimicrobial? Um, for patient at risk for MDR is low risk 7 to 8 days, while if the patients have a low high risk of MDR, if we either to go for 10 to 14 days or procalcitonin or CRP guided if procalcitonin is not available. When to consider stopping of the antimicrobial if the procalcitonin drops more than 80% or the absolute number is 0.3. With a very important point is the clinical improvement of your patients. Okay. The choice of antimicrobial for the first case, as we said, he has low risk of MDR, so we go for duration of 7 to 8 days. While for the another two patients, case 2 and case 3, we will go for 10 to 14 days, guided either by the clinical improvement or procalcitonin. If, as we said, if procalcitonin is not available, yes, we can go for, if CRP is decreasing more than 80% or less than 2, we can decrease or we can stop the antimicrobial. So to sum up, the definition of hospital acquired and endotracheal or ventilator associated pneumonia could be extended to 72 hours, not only 48 hours after ICU hospital admission or after ventilator or endotracheal intubation, and the diagnosis depend on the radiological findings. The very important point to have radiological finding, either with chest X-ray, CT chest, lung ultrasound, and we do remove the following finding, as we said before: fever, cough, leukocytosis, and declining in oxygenation, and the risk of MDR, either risk of MRSA or risk of high risk of a gram-negative MDR bacteria. Antibiotic choice according to the low risk patient single anti-pseudomonas pseudomonal plus or minus coverage in MRSA, while in high risk gram-negative MDR, we should start with dual antidominants with two different classes of antimicrobial plus the um, or minus coverage in MRSA. What are the evidence-based recommendation for VAB and HAB? According to the ITSA guidelines, we recommend that avoid as you can intubation if it's possible. Use the high flow nasal cannula or non-invasive ventilation. Minimize sedation. Avoid benzodiazepine. Interrupted sedation protocol. Elevation of the head. We and provide oral care with toothbrushing. No need for chlorhexidine. Ventilator circuit, change the ventilator circuit only if the visibly soiled. Early tracheostomy, consider early tracheostomy. It will not decrease mortality. It will decrease only morbidity. Early enteral nutrition as feeding versus parenteral. We, if it's visible to use to start the post pyloric nutrition, consider post pyloric rather than gastric in patient at high risk of aspiration. The also the recommendation of WHO and the CDC recommends that no rule of probiotic to prevent VAB. Oral chlorhexidine does not decrease the incidence of VAB. Also, continuous monitoring of the cuff pressure endotracheal tube cuff pressure does not decrease the incidence of VAB. And the also silver coated endotracheal tube continuous monitoring the gastric residual volume. Stress ulcer prophylaxis, it's mandatory for patients mechanically ventilated to prevent the decrease the incidence of stress ulcer, but it will not decrease the incidence of VAB. Early parenteral nutrition and also closed suction are not recommended to prevent VAB during in mechanically ventilated patients. Thank you.